everybody is using botulinum toxin in their every daily practice, and sometimes we need references or guidelines, recommendations, but it is very hard to find a universal one. Well, one is from United States, for example, one is from Europe, one may come from South America, or one may come from Asia, but not every single consensus recommendations, they really don't fit to universal patients. So what I was wondering was that what is the meaning of each consensus recommendation, and if there are some meaningful differences in individual recommendations, is that really related with ethnic or racial differences? So I collected class C level of a guidelines. This is what they call the grade approach. So class C means a consensus of authoritative expert opinions based on clinical evidence or from well-designed but uncontrolled or non-randomized clinical trials. That means that it is not, although it is not a double-blind randomized controlled study, but some of the experts' opinion and the opinions are standardized and published in the form of standard guidelines. So I found several guidelines through the literature. One was the most famous one in the year 2004 by Dr. Carothers, and another one came from Dr. Carothers in the year 2008. Many things have changed it, and two guidelines discussing on the use of Dysport. One was Dr. Kane from the United States, and one was from Dr. Benjamin Asher from France. So this is primarily a European guideline. And last year, Korean dermatologists, they published a paper regarding on the Korean version of a botulinum toxin treatment guidelines. So I collected the recommendations from those guidelines and compared some very detailed things and tried to find out what was the difference. Well, generally speaking, there were not much differences on dilution or reconstitution or storage of a diluted botulinum toxin products. Well, regarding potency units, everybody knows that Botox or Neuronox or Xeomin or BTX products have the same conversion ratio. Well, scientifically speaking, potency units are specific for each product and not interchangeable between products. But during the daily practice, we regard their conversion ratios 1:1. But Dysport has unique unipotency, as you all know that. Some people say that the conversion ratio between Botox and Dysport is 1:2. Some people say that the conversion ratio might be 1:3. But anyway, Dysport has a unique unipotency when compared to other botulinum toxin type A products. These are the botulinum toxin type A products available in Korean market. You can feel that Korean doctors are struggling in a very competitive battlefield of aesthetic medicine. Well, okay, let's talk about the further wrinkles. Well, Carothers' guideline in the year 2004 insisted that, suggested that 4 to 5 points, usually 6 points in 2 rows, and for females, usually 15 units of Botox were recommended, and for males, 20 to 30 units of Botox were recommended. But after 4 years, Dr. Carruthers reduced the amount of the total botulinum toxin injection. That means that after 4 years, even the very expert pioneers in the botulinum toxin research feel that not so the toxin amount was a little bit over-injected during the initial days. So I think it's a kind of a trend switching on the injection volume, injection units. Well, Dr. Kane's guideline is a bit different. Total dose is 20 to 60 units of Dysport. It's different from Botox or Neuronos, of course. Usually 40 units of Dysport were injected in total, and he addresses the the upper part and the middle part of the frontalis should be treated differently. And Dr. Asher's guideline is a bit different. He addresses additional injection on the lateral upper part of a frontalis is very important in part of their guideline. But the total injection dose of Dysport was similar to that of Dr. Kane. Well, according to the Korean recommendation guidelines, we recommended 9 points in 2 rows. Total injection units of Neuronox was 9 to 15 units. For females, the point dose was 1 to 1.5 units, and for males, 1.5 to 2 units of Neuronox was injected per point. So in summary, for forehead wrinkles, total dose is not that different between the guidelines, and every guideline is they are very emphasizing to skip the injection 2 to 4, even 4 centimeters from the upper orbital rim to avoid brotosis. And every guideline is saying that it's better to treat glabella at the same time for the holistic improvement. But what's unique in Korea is a additional injection points on the lateral part of the frontalis, and smaller point doses, of course, and it requires more injection. More injection points are required. So, what is the reason for such discrepancy? I don't know, but as you already seen, in Korea and in many Asian countries, the injection of a very small doses and very multiple injection points, the so-called microinjection of toxin, is so popular. So when we try the frontal area, even with very standard technique, it's the doctor's habit to inject small bolus of toxin in a multiple sites. Well, of course, there will be some cultural differences. Asians are known to be a little bit more conservative than Western people, and possible ethnic differences in anatomy. I don't know, but surprisingly, very little is known about the facial anatomy between races. For example, so male and female differences in frontalis anatomy is well known. Well, for example, the frontalis muscle dehiscence quietly differ from person to person and from male to female. So even though we don't know much about the racial differences in terms of frontalis anatomy, there is a possibility that, for example, Koreans and German people differ from their shape and size of the frontalis muscle. So I am quite interested in the anatomic study. Well, this is one of the Japanese article addressing the more laterally active distribution of a frontalis muscle fibers. Of course, we cannot totally believe just this article, but as you can see in this picture, many Asian people have they have very strong contraction of the lateral upper part of the frontalis. So it's always better to inject additional lateral injection for Asian people, because injecting just the medial central part of the frontalis sometimes causes a pseudo elevation of their brows. It's a good one if the patient wants it, but if the patient doesn't want it, that is a disaster. So Koreans really want to evenly stretch, evenly relax the whole area of the frontalis muscle. Well, this is another interesting anatomy study. Well, this study, this graph shows the relative individual muscle fiber diameters in microns, and it compared Japanese people and Austrian people. Well, as you can see, for example, orbicularis oris muscle fiber size doesn't seem to differ from races, but for example, frontalis, the individual muscle fiber size differs significantly. So if we consider the muscle size itself contribute much for the contractile strength, maybe Caucasians have a much more stronger frontalis muscle in terms of their contraction power. Well, about glabellar front lines, I don't find much significant differences between among 4 or 5 treatment guidelines. Nearly the same, but what is different is that Korean doctors prefer smaller total injection doses of toxin, and sometimes we try to inject just on the 3 points of the 2 points on the glabell corrugator and just 1 point for the procerus. So sometimes we skip the injection on the tail of the corrugator muscles. So possibly the size and strength of a corrugator muscle differs from people to people, and maybe there would be an ethnic difference in the anatomic structure of the corrugator muscle.